जी, अस्सलाम वालेकुम again. Acha ji. So we're talking about the mandibular movements. When we talk about the mandibular movement, it partly opens that it opens to the maximum protrusion, right? When the mandible starts moving. And likewise, just focus on the red line that I'm showing you. Can you see the screen, or is it still not visible?
No, ma'am. Still not visible.
Okay.
Yes, ma'am. Now we can see.
So when we open it, when the mandible is open, you just keep on focusing on the red line. The interior line is showing the opening path, and while the posterior line is showing the the posterior line is showing the opening part, in which there is slight opening and then there's maximum opening, and the anterior line is showing the closing part. And when it closes back, if you focus on this right picture, it closes back, it goes back to its original positions. So that is how the complete movement of mandible is performed. So in this way, we can say that when the mandible, it partly opens, and then the condyle, which is here in the mandibular fossa, it slight of moves or rotates. But when there is maximum protrusion, it glides downwards against the articular eminence. I'll show you in this picture as well, but we need to understand that during the movement of a mandible, the condylar the articular eminence has a great influence in directing the movement, the extent of the movement, right? So that is why we have to take care of it, especially when we are creating some form of prosthesis for the patient. Okay. So when we refer the same relationship and we want to replicate the motion of the mandible, we have to rely on an instrument like an articulator, in which this portion, the yellow portion of the articulator, is in fact depicting what? It is depicting the condylar element, or the condylar head, which is being replicated within the articulator as the condylar element, right? So we need to understand that that part is the condylar part is in fact showing that how the TMJ functions and how it is utilized during movement of the mandible. So what are the purposes of the articulator? Its purpose is to hold the maxillary and the mandibular casts in fixed determined position, because we are able to do it in the fixed, we are able to record the jaw relation even with the plain line articulator, the one that I'm so used to using it in making of different prostheses. The maxillary and the mandibular casts, they are held together in a fixed position. It is used to mount the diagnostic casts, and it is also used to simulate the jaw movement, not the path of the movement completely, but the extent of the jaw motion. And fabrication of occlusal surfaces, of course, when you're making prosthesis, you're creating occlusal surfaces, and arrangement of artificial teeth for removable complete and partial dentures. This is what you normally do, because even while doing an exercise, when you are arranging teeth, we make sure that you have mounted it on a fixed position on the articulator, right? So now let's focus on this picture. Although this is a picture of a molar, but it is, I would say, the main crux of understanding the occlusion as well as the articulation, why it is important to articulate, especially when you are making complete dentures. So there are 5 aspects of this picture, if you would look at it. And these 5 aspects are known as Hanau's quint, right? So what it is in fact showing that what are the things that are to be taken care of while rehabilitating a patient's occlusion. And these are, if you just remember these things, these few things together, so you would be able to easily understand the rest of the concept. So it is what? I'll start from this side. That's inclination and plane of orientation. Inclination of condylar guidance. I'll just explain one by one to you. Prominence of the compensating curves, the height of the cusps, as well as inclination of the incisal guidance. So we will take up one by one that what is the incisal guidance. Can anybody tell me amongst you that what is the incisal guidance? आप में से कोई बताएगा कि इंसाइजल गाइडेंस क्या होती है? डू यू हैव एनी आइडिया? अभी आपने आर्टिकुलेशन का, जॉ रिलेशन का थोड़ा बहुत पढ़ा भी है पिछले लेक्चर में. मुकम्मल खामोशी छा गई है. Shall I take names? Aiza? चलिए. अच्छा, incisal guidance is in fact the influence of the parietal surfaces of upper central incisor or upper anterior teeth when it will contact the incisal edge of the lower anterior teeth. It is going to direct the movement of the mandible. So it is going to provide a guidance for the movement of the mandible. That is why it is known as incisal guidance. Okay. So आपको कैसे पता चलेगा कि upper parietal surfaces अगर इस तरह inclined है, अगर थोड़ा सा retroclined है या proclined है, the influence that the parietal surfaces of the incisor is going to have on the movement of the mandibular. How? When the patient will be asked to open the jaw, the lower anterior teeth are going to come in contact with the parietal surfaces up to a certain extent, and then the mandible is going to change direction. So incisal guidance does have a role. It is also known as anterior determinant of the occlusion. So it's very important that we take care of this incisal guidance, especially in patients in which we want to give us a little bit of overlap, the deep overlap, and we try to maintain the angle of the incisal guidance table according to the overlap that we want to plan for that particular patient, so that the movement is really smooth. And then we move on to the condylar guidance. So if you look at this picture down there, it actually shows the anatomy of the temporomandibular joint. And in that anatomy, you would see that the condylar head is residing where? It is residing within the glenoid fossa, against the thin avascular portion of the articular disc. And if you look at the upper picture, when the condyle moves downwards, it comes across what? The slope, and then a little bit of interference, and that slope is known as the condylar guidance. It is the posterior slope of what? The articular eminence or the anterior boundary of the mandibular fossa. So for this condylar guidance, the dentist does not have any control for the posterior determinant, obviously, because it depends upon the anatomy of the individual. You would not know, you would accept, you would try to record this guidance or record this relationship just to transfer it on the articulator, and it will act as a posterior determinant of the occlusion, but you cannot change it. Rather, you are going to modify your occlusion according to the steepness or the shallowness of the condylar guidance. Okay. Then we have the cuspal heights. Now, the cuspal height kya hai? It is measured by the angle formed by the mesiobuccal cuspal incline to the horizontal plane. The angle which is formed is known as cuspal height, and when the long axis of the tooth is vertical to the plane. So, well, this is in your control. The condylar guidance was not in your control, but depending upon the steepness or the shallowness of the condylar guidance, you can select your cusp. Whether you are going to select a steeper cusp, or you're going to select a shallower cusp, or you're going to select somewhat in between them. So we know by now that the teeth that are available for setting up of or making complete dentures, they come in different ranges. We have anatomic teeth, and we have semi-anatomic teeth, and we have monoplanar flat occlusal tables, right? So anatomic teeth are mostly of 33 degrees, then we have 30, and then we have 20 degrees, depending upon the steepness of the cusp. When we say that the angle is getting reduced, we are going towards the shallow cuspal occlusion, and then we have 0-degree teeth in which there is no cuspal incline. So depending upon the articular eminence or the indication of the patient, we are going to do the tooth setup. Then what do we have? The compensating curves. We are a little bit familiar with the compensating curves from second year as well, that we don't make or we don't plan the setup in exactly horizontal plane. We elevate slightly the posterior part of the occlusal table. We slightly give some tilt to the mesiodistal aspect of the table, just to compensate the curves. And I will explain in the next lecture that why do we want to utilize this anteroposterior curve and mediolateral curve, what are the theories behind it. But right now you need to understand that these compensating curves are to be utilized and they are to be placed there just to make a proper occlusal table. And then the fifth portion of that Hanaud's point was orientation of the occlusal plane. So if you look at this picture, the radiograph, it is going to show you the occlusal plane just above this red line. You can see that the occlusal plane is showing a certain tilt, and it's showing its orientation with reference to what? With reference to the Frankfurt's plane, right? Which is visible where? Which is visible from the chorion to the lower portion of the orbital, right? So that in reference to that plane, the occlusal plane can be in this orientation, can be in this orientation, can be a little steeper. So it depends upon the orientation of the occlusal plane. And this you will determine if you're going to record the orientation relation record, which is the FACEPO record. And that is when you are going to modify your occlusion according to that. So these are the five important aspects of setting up of teeth, and we need to take care of it. Now I would like you to watch this video, because it's going to show you.
Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide. Podcast series, promoting oral health care.
Glass can be attached to an instrument to you must use an instrument to simulate the patient's jaw movements and to hold mandibular positions. We use an articulator. This instrument simulates the temporomandibular joints of the patient, and dental casts can be attached to it. Now, graphically, if we look at the skull, we can see the condyle in the lower or in the mandible, and then the infratemporal fossa of the maxilla. Superimposed on the graphic illustration of the skull is a graphic illustration of an articulator. The lower member of the articulator representing the mandible of the patient, and the upper member of the articulator representing the maxilla of the patient. Now, we have also superimposed dental casts. These are positive reproductions of the patient's mouth, and these are mounted to the mechanical device which is simulating the movements of the patient. Now, many times, or many types of articulators are used in dentistry, from the very simple type of articulator to an average type of instrument to a more complex type of an instrument. Now, the differences being, besides cost, the fact that this very simple hinge-like articulator is not capable of reproducing the movements of the mandible to any degree of accuracy. There's only slight movements about the hinges in the posterior, little springs rather. Now, as you go to the average type of instrument, we have average dimensions of a patient built into this articulator. These average dimensions will give us, when we move the articulator, a more accurate reproduction or simulation of the patient's movements. Going further to the more complex instrument, it takes from the patient a more complex type of recording to set the articulator. This articulator is then further more accurate in duplicating the patient's movements. We're going to use the skull to review some basic anatomy and some basic mandibular movements. we see, first of all, the mandible, and we see that the condyle with the disc, the blue disc, fits into the infratemporal fossa. Now, with the skull in this position, we're going to duplicate the hinge movement of the skull. It is rotating about a transverse axis. This is the hinge closure. Now, we can also use this view to look at the protrusive movement of the mandible. If we allow the jaw to come forward, we see that the condyle and disc come forward.
Can you see over here the extent of the influence of the condylar guidance on the movement of the mandible? In this picture, it's very clear that the extent of this slope is going to direct how the mandible moves in the protrusive movement.
And it is guided by the posterior slope of the anterior slope of the eminence. Now, this movement is a translatory movement. In other words, the condyles are coming forward in a bodily fashion, as opposed to, they come forward in a bodily fashion as opposed to a hinge type of movement. There may be, in protrusive and opening movements, a combination of hinge and translatory movements. Now, changing the position and looking at it from the anterior, we will simulate lateral movements of the mandible. Now, the lateral movements of the mandible, as you have previously learned, the condyle to which to the side which the mandible is moving, which in this case would be this skull's right side, stays in a relatively still fashion. Now, as we move, it will come outward just slightly, and that slight outward movement of that condyle is called a Bennett's movement.
Okay, now this is important. When the condyle is moving onto the working side, we call this working side, or which direction the condyle moves. So we need to understand that it's going to just rotate and go slightly on this side. So we call this Bennett's shift. Okay, so what do we call it? Bennett's shift. So this is what he's showing. It will be on the working side, right? Where which direction the condyle moves.
And the side to which the mandible is moving is called the working side, or that would simulate a chewing side. So this is the working side, the right side. When the teeth are in the working relationship, it is the buccal cusp of the lowers in line with the buccal cusp of the uppers. The opposite side, the left side, would then be termed the balancing side. Now, the condyle on that side is coming down and forward and to the medial aspect. Now, we're going to have to get the skull in a little different position so that we can look at that balancing condyle. You can see the balancing condyle coming forward. The balancing condyle is coming forward as well as moving medially. And we'd like to show some of the parts of this Hanaud articulator. The Hanaud 2 model articulator is an average type instrument and is capable of only a portion of the movements that the patient can make. It will not be accurate to the nth degree.
Let me clarify a few things over here that you have up till now. What we have seen is we have seen the anatomy, that how does it work. We have seen the movement when the mandible is when the patient is trying to open the mandible, and when we have seen the movement when the jaw is being shifted to one side, what happens to the condyle then? When the jaw is moved forwards, what happens to the condyle then? And when the jaw is moving on one side, what happens to the other condyle, in which it comes downwards, forwards, and medially. Okay, so now we know what are the different kinds of the movements. Now we are going to look at the different parts of the articulator, that how they are going to help us in achieving those kind of movements. So this Hanaud articulator that he is going to explain is one of the types of the semi-adjustable articulator, but Hanaud is the name of the company. We have a variety of instruments, variety of companies by different manufacturers who do make these instruments nowadays, right? But we need to understand the mode of action or the mechanism involved in the construction. It's going to be almost similar. Just you need to understand or grasp the basic concept of it. Chinni.
It is only an average replication of the patient's movements for some of the reasons I'll show you a little later. Now, the upper part of this articulator that I'm arcing up and down, this is called the upper member of the articulator. It is composed of the upper member proper and a posterior, or looking at it from the posterior, a horizontal axis, or horizontal or transverse axis. The opening and closing movements of the articulator are centered around this transverse axis. The incisal pin is also attached to the upper member of the articulator, and its purpose is to prevent a closing of the articulator if the stone casts, for example, start to abrade on the occlusal surfaces. The incisal pin helps to maintain the vertical dimension of the articulator. Without it in and without the cast in, the upper member of the articulator would collapse to the lower member. Now, looking at the lower member of the articulator, we see it has a condylar element. It has a vertical axis and a lower member proper with an incisal guide table. For now, we're going to concern ourselves with the...
Here, I would ask you to focus upon this thing that we have an incisal pin and an incisal guidance table. So these are two different things. Incisal pin is considered to be attached, although it's a removable thing with the help of the screw, but still it is considered to be attached with the upper member of the articulator, while the incisal guidance table is going to be attached with the lower member of the articulator. And this condylar element and the condylar guidance, it is going to be different in Archon and non-Archon articulators that I'll explain to you further, inshallah.
Condylar element and the basic movements of the articulator. We've already illustrated one, the opening and closing movement about a transverse or horizontal hinge axis. If we look closely at the condylar element, we will see that the condylar axis is moving through a center ball. The ball is representative of the skull's condyle. Now, if we open and close, the transverse axis is rotating through the center of the condylar ball. Now, we want to look at the track which the ball is held in. This is the horizontal condylar guidance. And this can be adjusted to what the patient's records may give you. If the patient has a steep condylar guidance, we set it such, and it could be very shallow or near zero. Now this becomes important in the second movement that the articulator is capable of making, and that is a protrusive movement. Looking at it from the...
So up till now, we have learned the different parts of the articulator. I want you to first focus on the parts, and then we are going to focus upon that what are the functions of it in the remaining part of the lecture. So you have gone through this, the Facebook record, the orientation relation record. How do we take it? We know that it is required, especially in partially dentate individuals. It is required for mounting the cast onto the articulator. When the face was recorded, this is how it is taken out from the patient's oral cavity. This is the mount that is required in order to connect it with the help with this articulator, right? So these mounts help us in placing the exact position, in placing the cast in the exact position in which it was in the patient's oral cavity, and this help us in mounting the upper member to the articulator with the help of plaster. So just focusing upon the different parts of the articulator, that the triangular framework, the upper member, the vertical rod with the thin screw, two condylar elements. You have just seen that in the video. I just want to emphasize upon the parts right now that this is the complete upper member. This is where the incisal pin goes, and these are the two condylar elements. Then we have a lower member in which it's an L-shaped frame in which there is a table which is meant to receive the incisal pin, and it also has a slot which receives what? Which receives the condylar element, and it also acts as a guidance. Sometimes it is filled with the spring, sometimes it is not filled with the spring. And now we know that the incisal guidance table, why it is used, it is slightly concave. Why? Because it is replicating the incisal guidance which is provided by the parietal surfaces of the upper anterior teeth, and the vertical rod, it rests on the center of the incisal guidance table. So this is the pole. I would like you to take a screenshot of it so that you can immediately respond to the pole. Please take a screenshot of this portion. Submit. चलिए जी, ये क्वेश्चंस आपके सामने नजर आ रहे हैं? इनको जरा इनका जवाब देते। 4 क्वेश्चंस हैं। Can you see all these questions?
Yes.
चलें, चारों सबको सिर्फ लेबलिंग आपसे पूछिए। फिफ्टी में से भी only 7, 8. All of you have done? चलें 32 हो गए, शाबाश। बाकी लोग भी दे दें जवाब। मुश्किल लग रहा है जवाब देना?
Excuse me, ma'am. मैम आप फोर्थ की ऑप्शंस रीचेक कर लेती हैं?
और फोर्थ की ऑप्शन
आप रीचेक कर लेती हैं? मुझे लगता है सही ऑप्शन नहीं है उसका।
उसको रहने दो, फोर्थ को रहने दो, फर्स्ट 3 कर दो।
ठीक है मैम।
ठीक है। बाकी लोग भी वोट कर लें, 34 में से बाकी 50 आप लोगों ने नहीं करना। हम्म 35. What about the remaining 16? चलिए, so next time आप लोगों ने कर लिया तो I'm going to end it. Next time inshallah I'm going to tell you the key of this and we will complete the remaining functions of the articulator. ठीक है बेटा?
Yes, thank you so much.
Who has left with it? कोई किसी ने और जवाब देना है? अभी I've just received 39. चलिए, I'll just end it up. ठीक है, नेक्स्ट टाइम हम बाकी इंशाल्लाह देखेंगे, बिकॉज आपकी अगली क्लास का टाइम हो गया ना।